All right, so now we're moving forward into pediatric immunology. And immunology, even in step one, was a topic that was very annoying for a lot of students because there was so much to know, right? So many different disorders. So back in step one, the immunology chapter itself, of course, involved understanding the differences between what your B cells do, what your T cells do, the innate and adaptive immune system, the humoral versus all the other different cytokines and all of that. So overall, it was a lot of content of stuff to actually learn. So at least in that aspect, it wasn't silly. Like it's actual stuff to learn, not like farm KMV Max or biochem memorization stuff. It's actual knowledge based things, and you have to be very confident in knowing what each component of the immune system does, right? Whether it's the MAC system, the complement system, the different types of B cells, and then of course you also have to know the various CDs that were all on each of these, the different kinds of T cells and what each of them do, and then you have to understand the different kinds of issues people can get and how they're all dealt with, right? Whether it's viral, bacterial, fungal, right? Some yeast thing, candida, all of that stuff, and then of course having autoimmune conditions, and that also played another role back considering with autoimmune conditions and how you're going to treat them, right? So here we see on our screen right now are the immunodeficiency disorders, which are in step one first aid, broken up based off of where the disorder is, whether it's a B cell disorder, a T cell disorder, a mixed B and T cell disorder, or some kind of phagocytic dysfunction. Now, based off of what the disorder is, that's the kind of infection you'll generally get, right? So we're going to see more about that as we go on. So in the first thing they talk about here, congenital immune deficiencies are rare and often present with chronic or recurrent infections like chronic thrush, unusual or opportunistic organisms, incomplete treatment response, or failure to thrive. Categorization is based on the single immune system component that is abnormal. So of course, first thing you have your B cell deficiencies, right? So in here you can see your B cell deficiencies are X-linked Bruton A gammaglobulinemia, selective IgA deficiency, and common variable immunodeficiency. So that's your entire group of every single thing that we actually care about. So first, right here, most common B cell deficiencies typically present after 6 months of age with recurrent pulmonary, GI, and urinary tract infections with encapsulated organisms like Haemophilus influenzae, strep pneumoniae, and Neisseria meningitidis. You basically treat this with IV immunoglobulins, except the IgA deficiencies, right? Because if you don't have B cells, you're unable to make immunoglobulins, so you just give them IV immunoglobulins, and it requires lifelong treatment, maintenance therapy for their immune system. Now, one of the key things here typically presents after 6 months of age, right? So the first 3 to 4 months after being born, they'll be fine, and maybe in month 5 they'll start getting a little sick, and after that their sickness episodes are going to be more and more. So maybe the patient might present at age 7 months saying for the past 2 weeks they've had 2 different kinds of infections, something like that. The reason this occurs is because up to that age of 6 months, the maternally given immunoglobulins are still there. So all the immune system components that the baby got from the mom upon being born are still there. Once they diminish, the sickness episodes start to occur more commonly, right? So that's one of the big issues there. Let me just say something real quick. So that's something you pay attention to. And the first thing right here they talk about Bruton's A gammaglobulinemia. That's the first disease in step 1 first aid as well. Can be confused with transient hypogammaglobulinemia of infancy. This is not mentioned in step 1. So even here they don't tell you that, oh, don't confuse it with transient hypogammaglobulinemia of infancy. But both of them are very similar. Both are characterized by increased susceptibility to infections at around 6 months of age. When the transplacental maternal IgG starts to run out. B cells are low in Bruton, whereas those in THI are normal, right? So in this, the transient hypogammaglobulinemia of infancy, the amount of B cells will still be normal. Okay, so what happens the next thing, agammaglobulinemia, this is agammaglobulinemia, not hypo, but they can look very similar in terms of presentation. So here, there's a defect in BTK, a tyrosine kinase gene, which then leads to no B cell maturation. So they have only immature B cells, which are theoretically dysfunctional. They don't do anything. So in effect, they have no B cells. So that's what you see, absent B cells in peripheral blood, low immunoglobulins of all classes, right? IgG, IgM, IgA, all of that. And you're going to have absent or scanty lymph nodes and tonsils. The primary follicles and germinal centers are just not going to be there. And those are the places where you have your B cells. So for these people, you cannot give them any live vaccines because they won't be able to actually fight the live bug you're putting into them. These patients present with recurrent bacterial and enteroviral infections after 6 months when maternal IgG goes away. So of course they're going to get a lot of bacterial infections because they don't have B cells, and then their gut is no longer protected because you need IgA to keep your gut safe, and they don't have any Igs, no Igs at all. Right, so you're going to see this right here, presents with recurrent H. influenzae, mycoplasma pneumoniae, hepatitis, enteroviral CNS infections. Treatment is with IVIG every 3 weeks for life, okay, because they can never actually make their own. Patients' lymph nodes will lack germinal centers, and you're not going to find these CDs, which are actually just found on B cells, CD 19, 20, and 21. 21 being notorious for what was that virus? Whatever that virus is, you guys know. So that virus can no longer infect them because it uses CD21 to actually infect them. And then I had this little mnemonic here, BTK, just to remind you of bad tyrosine kinase, right? Just in case you get a very physiological question on the pathophysiology of how this works, right? So their tyrosine kinase gene just isn't working. That's all it is. Now, identifying this in questions is, very challenging when you're new to this, because you're going to get questions that often look very similar, where, in all of these, especially in all three of these, patients often seem to present with the same recurrent infections. But it's the presence of certain infections and any little key things they might mention here and there in questions that really helps figure out exactly what the problem is. I don't have too many practice questions here, and most of the practice questions I did have were in the micro chapter, but we'll see them as we go on, especially if I put any. Now, I don't even have any here because there really aren't that many I've actually found when I was doing the pediatric stuff with students. But again, as you find questions, of course, do what I do, put them here, or make note of key things in that question that were supposed to help you figure out it is actually Bruton's and not something else like severe combined immunodeficiency or something else. And we're going to see those differences as well as we discuss. Right, so key thing here was just recurrent bacterial and then enteroviral infections. And some of those enteroviruses also cause CNS infections. This is why I wrote it like this, enteroviral CNS infections like polio and stuff. All right, so we're going to see some of those things as we go on, and we're going to differentiate the presentation with others. So then they continue to tell you Bruton agammaglobulinemia and common variable immunodeficiency, CVID, also have similar symptoms, but the former is found in boys under 6 months of age, around 6 months of age, whereas CVID is seen in older men and women, and its symptoms are less severe. Right, combined variable immunodeficiency is another differential right here. Right, it's also a defect in B cell differentiation. Cause is unknown, so you won't get tested on that. Usually presents after age 2. So you see the only difference between these two questions at face value would be, I can literally take the same exact question and just change the age. That's it. So here it might be a baby that's 7 months old, whereas here it might be a child that's 3 years old. So usually presents after age 2 and may be considerably delayed, so even older, like 30 years old. Increased or high risk of autoimmune disease, bronchiectasis, lymphoma, and sinopulmonary infections. Right? Low plasma cells and low immunoglobulins. So they don't have the plasma cells because, again, you need B cells for that. And they don't have any immunoglobulins because you need B cells for that. But keep in mind that both of these groups, the top and the bottom, do have T cells. However, one of the critical things about that is that in the beginning here, you learned the interaction between B and T cells, this thing, right? T and B cell activation, where T cells find things, right? They'll recognize something that's there that wasn't supposed to be there, right? That dendritic antigen presenting cell is then going to go ahead and bring it to an, this dendritic cell is going to bring it to a T cell. The T cell finds it, recognizes it, understands there's a problem here. T cell activation occurs, right? This is where this connection between MSC and T cell receptor is going to activate the T cell to go do its job. Now, this T cell is supposed to go connect with the B cell, right, for the second stage, where now you're going to have cytokines and Ig class switching, and you're going to make the different types of immunoglobulins you need to go fight something. So when you don't have B cells, although you may have T cells, your ability to do something is not really that good. The B cells are the main attackers. They're the main, assault weapons that we have, and they're not going to work too well. So if you forgot this class switching and activation stuff and the 2 signals that are necessary, again, this is important key knowledge that you do need to retain. So you should definitely revise this, make sure you get it down, understand what is actually happening here. All right. Let's go back to our page that we were at, and then in the middle, so that's your CVID, BTK. I just call it BTK, but Bruton's A gamma X-linked. This is X-linked, by the way, so it's almost never in a girl. That's another thing to help. If you get a question where it's a girl presenting with all the symptoms of Bruton's A gammaglobulinemia, then it's probably not Bruton's A gammaglobulinemia, and it's probably CVID. That's a very little thing that would help you get that question right. Right? If it's a female infant with all the symptoms of Bruton's, but Bruton's is X-linked, that for a girl to get it, both parents would have to have symptoms of Bruton's. And if they don't mention that in the question, that both parents have also had recurrent bacterial infections since the day they were born, both parents also get IgG since the day they were born, then there's no way that the girl got Bruton's, right? So it's a guy that would have Bruton's A gammaglobulinemia. So that's why the B is very critical here. Bad tyrosine kinase, no B cells, only in boys, right? If you have a girl with all these symptoms, it's probably CVID. Whereas selective IgA deficiency is just not having IgA, but they do have IgM, IgG, all of those things. So they can fight everything except all the bugs that are supposed to affect your lumen, your whole luminal system, from the mouth all the way to the end. Right? So majority are asymptomatic because, again, it's only IgA that's missing. But what you will see is airway and GI infections, some autoimmune disease, atopy, anaphylaxis to IgA containing products. Remember, there was a problem when you want to give blood supplies, right? Giving these guys a blood transfusion with IgA in it will actually cause a type 1 hypersensitivity allergic reaction to the transfusion in 3 hours, right? Usually transfusions are type 2 hypersensitivities, but this is a type 1 allergic anaphylactic reaction to IgA containing blood products. Right, so oftentimes this question cannot present with that, because this would be a great way to ask you a question about immunodeficiency as well as a blood transfusion problem. All right. So here I wrote, patients may have a history of recurrent pneumonia, diagnosis of celiac disease, which is one of your autoimmune diseases, and an anaphylactic reaction during blood transfusion. Some may have recurrent sinopulmonary and GIT infection. Regardless of what it is, it's not going to include like a lot of infections that are outside of the lumen, so like skin infections all the time or otitis media all the time. No, those are not the things happening here. Right? These are just airway and GI infections nonstop. Right? And they also, celiac is a favorite of theirs for autoimmune, because they don't actually have to tell you that the child has celiac. Right? The child may be too young to have had actually experienced, those foods that would trigger celiac disease. But the child may have symptoms, especially those physical symptoms like the hepatitis multiformis, those weird herpetic lesions on the elbows and knees and wherever. Right? They'll mention some of those things to make you think, oh, that lesion is probably celiac disease. And then you have to catch that, oh, this is selective IgA deficiency. So these are your only B cell specific disorders where you're missing B cells. Right? And they're kind of sort of in order of what's good to what's worse. Okay. This one is actually good. This is the worst one. Right? Bruton's is the worst one. This is really problematic. You have absolutely no B cells. Here, IgA deficiency is okay, but it just sucks to not have IgA, because your luminal system is very critical. Airways and GI. You need food, you need air. So that's very critical that you've messed all of that up. And then common variable immunodeficiency is variable. It's not that problematic. It's just a defect in B cell differentiation, but there are B cells. Okay, and these people, their only big problem is just autoimmune disease. So depending on what autoimmune disease they're developing, overall life should be okay. Then you have your T cell deficiencies. These tend to present earlier because you don't really get much T cell action from parents. So 1 to 3 months age, right? With opportunistic and low grade fungal, viral, and intracellular bacterial infections. Look at the difference in the category of what type of infection you're getting, right? B cells, they were typical high yield bacteria, H. influenzae, strep pneumo, Neisseria meningitidis, right? The things that were infecting B cell deficient patients are different from the things that are infecting T cell deficient patients. So, of course, in a question when they tell you what kind of repetitive infection someone is getting, that helps. And then the other critical difference is the age of presentation. Right? These are going to be some critical things for you to figure out what the disease is. And in B cell deficiency specifically, Bruton's is always boy. Right? So if they have a girl with all those symptoms, then it's probably CVID. Whereas IgA deficiency is literally just IgA deficiency, so only luminal infections, airway and GIT. That's it. As a B cell, big time bacteria. Here, fungal infection, viral infection, and intracellular bacterial infection. Bacteria that you can't really kill with IgG and stuff because they're inside cells. Right? So that would be your mycobacteria, for example. Secondary B cell dysfunction is also seen for the same reason as I just showed you guys. The I think that's page 109. Where is it? This, right? T and B cell activation. If you don't have T cells, then you can't even try responding to something that an antigen presenting cell is bringing to you. And if you don't have B cells, at least your T cell recognizes it and it still is able to release these cytokines, right? But the B cell is supposed to be the one that actually goes and attacks things, so then that's still going to sort of be faltered, but it's better. It's okay. Not having T cells is worse. Not having T cells is really problematic because not only did you not get many T cells from mom, so the infection presents earlier, but also because without the T cells, you don't even recognize the things your antigen presenting cells are bringing to you. So they mention, oh, they don't even mention more of the diseases here, right? They listed it out. Okay, they did mention it in the table, but here they're just listing out symptoms. Okay, got it. So we talked about Bruton's, right? Bruton's X-linked recessive B cell deficiency found only in boys. Symptoms begin after 6 months of age when maternal IgG is no longer active. Life-threatening, characterized by encapsulated Pseudomonas pneumoniae and Haemophilus infections after 6 months. Perfect. Quantitative Ig levels are going to help you do the diagnosis. If it's low, confirm with B and T cell subsets, right? Check what's actually missing. That would be a qualitative Ig level. Absent tonsils and other lymph tissue may provide a clue. Treat with IVIG for life. Every few weeks they'll have to get it. Great. So that's a perfect explanation of what's Bruton. Then there's CVID, usually a combined B and T cell defect. All Ig levels are low, but normal B cell numbers. Right. Also, this is going to be a boy or a girl. For Steph, as much of an asshole as they might seem sometimes, they do help. So most CVID questions will be a girl, right? And Bruton will be the boy patients. So this is probably going to be a girl patient presenting with very similar symptoms as Bruton's, right? High pyogenic upper and lower respiratory infections, high risk of lymphoma and autoimmune disease. Quantitative Ig levels confirmed with B and T cell subsets, same thing again, right? And treat with IVIG for life because they're never going to eventually start making the Ig they need. And then the IgA deficiency. Mild, the most common immunodeficiency, low IgA levels, usually asymptomatic, but patients may develop recurrent respiratory and GI infections, especially Giardia is a giveaway in these questions. Anaphylactic transfusion reaction caused by anti-IgA antibodies is a confrontation, so if you're going to give them a blood product, you have to make sure you take the IgA out of the blood product. Again, just check for quantitative Ig levels. They're going to have a lack of IgA, and you treat the infections they get. Be careful giving IVIG as it can lead to the production of anti-IgA antibodies. So you can't really say treat with IVIG because remember, you just cannot give them IgA. Since these patients never made IgA, to them, IgA is a outsider. So if you give them IgA, they start attacking that IgA itself. Right? But IVIG is necessary. Just make sure it's IgA depleted IVIG. So no IgA for them at all. Why is hyper IgM syndrome here? Let me see. Hyper IgM syndrome is being T cell disorder. That comes later on. T cell disorder, combined disorders. Interesting. They have a little bit of a different order here. They put this under B cell disorder, but in step 1, hyper IgM syndrome is in the combined things. So we'll just look at it like that. Right now, though, we were talking about T cell deficiencies. So I'd like to jump over to looking at the T cell deficiencies. So T cell deficiencies, you have your thymic aplasia, interleukin 12 receptor deficiency, very nice one to understand, autosomal dominant hyper IgE job syndrome, and CMC, chronic mucocutaneous candidiasis. Now, what's happening here? So, thymic aplasia, we know, is most likely related to DiGeorge syndrome, right? 22q11 microdeletion, failure to develop third and fourth pharyngeal pouches, absent thymus and parathyroids. DiGeorge syndrome is a thymic parathyroid cardiac defect, with velocardiofacial syndrome being another variation where there's pallid, facial, and cardiac defects, but no parathyroid and thymic issues. Okay, so the facial issues are going to be the giveaway to velocardiofacial syndrome versus DiGeorge syndrome, because cardiac defects are not that evident in differentiation wise when you get these questions. Give me 1 second. So here, catch-22, that was the main mnemonic for memorizing this. Cardiac defects with conotruncal abnormalities like tetralogy of Fallot or truncoseptoriosis. Any of those early cyanosis cardiac defects. Abnormal facies, thymic hypoplasia, T cell deficiency with recurrent viral and fungal infections, because that's what happens when you don't have T cells. Cleft palate, hypocalcemia, secondary to parathyroid aplasia, which then leads to all the symptoms of hypocalcemia. Low T cells, low PTH, low calcium, right? So this is usually weird, right? If you have low calcium, then PTH should respond by increasing, and that's not going to happen here. And thymic shadow absent. That usually you won't see. So this here is the thymic shadow. If they give you a chest x-ray of an infant and there's nothing wrong with the lungs and the heart is there and everything else is okay and there should be that little gas bubble there, everything's okay, then they're probably trying to show you the thymic shadow, which is literally a shadow, so it's a little hard to actually visualize, but it is there. All right. Here they say for thymic aplasia, let's see what they mention. Thymic aplasia, DiGeorge, see the mnemonic catch-22, which we just did. It is autosomal dominant, right? They don't mention that here. It is autosomal dominant. All right. Variable risk for infection. A lot of infections with viruses, fungi, and PCP, pneumocystis pneumonia. Remember, PCP infection was usually just a HIV thing, right? Usually just HIV patients who get the pneumocystis pneumonia, which you have to check with silver stain, and it looks like a little cusp, a little black seed in bluish stain, if you ever see the histoimage. Absolute T cell count is what you need to check for. Mitogen stimulation response is something you can check for. And delayed hypersensitivity skin testing, because of course they don't have the T cells to actually do the response. Treat with bone marrow transplant and IVIG for antibody deficiency. Give PCP prophylaxis with that's the TMP sulfamethoxazole. Thymus transplantation is an alternative, although not really commonly done. First of all, it's not really easy to get a thymus, and second of all, if you do the transplant, it's still not 100% that it's going to fix the issue. So this isn't really done. The more effective thing is to do the bone marrow transplant. There's a very low chance of bone marrow rejection also, because they don't have T cells, so they really can't reject it that well. And it should do the job and help them make the T cells they need. Right. So that's your thymic aplasia. So they really should have written it's autosomal dominant. I didn't even remember that actually, so that's pretty critical stuff right there. Next one, interleukin 12 receptor deficiency. So what is this so special about, and why is this a problem? So earlier, when they were showing you all the lymphoid structures and cellular components, they taught you that interleukin 12 and interferon gamma both cause differentiation of the naive T cell to Th1 cells. This is something you had to spend time actually getting down from this table right here. Right, so back when we were studying for step 1, in my step 1 videos, I made a bunch of memorization tools using numerical play to kind of make this stick. Right, so right here we're seeing interferon gamma and interleukin 12 cause helper T cells to become Th1, and Th1 cells then go activate macrophages and cytotoxic T cells to fight infection. So now if you have interleukin 12 receptor deficiency, then all the interleukin 12 that's being made will not activate Th1 transformation. So obviously, naturally, you can see if there's two things that can trigger this transformation, then you just give the other thing, interferon gamma, right? And that's what we're seeing here. So they tell you low Th1 response, autosomal recessive, disseminated mycobacterial and fungal infections may present after the administration of the BCG vaccine. Very easy treatment though, you just give them interferon gamma, which will then cause Th1 response, right? You'll start making Th1 cells. So it's like one of the easiest to deal with. Slightly difficult to actually identify in the question because it's going to look very similar to a lot of these other guys. You're always going to have to pick out symptoms that are present and symptoms that are not present to really figure out what the problem is. Right? You're going to have to see, oh, but this patient doesn't have hypocalcemia, so then it's probably interleukin 12 receptor deficiency, not thymic aplasia. Or you'll see some of these other symptoms that these other guys have, and it's going to be different from it. Right, so interleukin 12 receptor deficiency, very easy to deal with. Just give them interferon gamma, they'll be all right. Let me see if they mention anything about it here. No, they don't even have it here. I don't see it. Okay. Next one, autosomal dominant Job syndrome. Right, so Job syndrome, deficiency of Th17 cells due to STAT3 mutation, leading to impaired recruitment of neutrophils to the sites of infection. This most commonly gets tested with non-inflammatory abscesses. Right, an abscess that isn't inflamed because there's an abscess, but the neutrophils never actually made it to the abscess. Right, retained baby teeth, coarse facies, dermatologic eczema, high IgE, very high IgE, and bone fractures from minor trauma that may resemble osteogenesis imperfecta, but it's, osteogenesis imperfecta has a good immune system. This condition mainly gets tested by telling you that there's eosinophilia and high IgE. Eosinophilia, when it's really high eosinophil count, you usually consider that the patient may have some kind of parasitic infection or they have leukemia, which again, if it's a young baby, leukemia is possible. That's one of the most common cancers in younger children. So you have to be very careful in figuring out what the actual problem is. Right? This is hyper IgE Job syndrome. Patients, one of the parents are going to have it as well. Let's see what they talk about it over here. Or if they talk about it. Oh, here we go. Job syndrome. Hyperimmunoglobulin E syndrome. Hyper IgE syndrome. Defective neutrophil chemotaxis. The neutrophils cannot go where they need to go. They have their own mnemonic here. Faded. Right? Abscesses. The abscess is non-inflammatory. I think this is one of the key things that will really ring a bell if they even mention it in a question. And just a lot of IgE and eosinophilia. The question may actually start with a patient coming in because of their eczema, right, which also starts with an E, so it should hopefully ring a bell for you. What do you do for them? Treat with penicillinase resistant antibiotics and IVIG. That's it. Right, they don't have, so they have so much IgE, but they don't really have the other IVs, the other immunoglobulins as much as they need. Too much IgE production, everything is being converted to IgE, so not enough for the other IgG, IgM that you do need as well. And then last one on this page, chronic mucocutaneous candidiasis. T-cell dysfunction, heterogeneous group of immune system defects, impaired cell-mediated immunity against candida. Classic form caused by defects in AIRE, which was actually talked about earlier in the book right here in step 1. So now they have T cells, but they don't really work that well. And the main issue here, all we're seeing is candida, which is in the name, chronic mucocutaneous candidiasis. Non-invasive, so it's not hematologic, okay, it's not in their blood, non-invasive Candida albicans infection of the skin and mucous membranes only. They're going to have absent in vitro T cell proliferation in response to Candida antigens and absent cutaneous reaction to Candida antigens. So this is a very specific issue that's usually pretty easy to identify, and as you can tell, it's very different from the other guys. So not so bad. All right, let's keep going. After this comes your mixed things, B and T cell disorders. However, they talked about hyper IgM syndrome as a B cell thing here. So let's take a look at why that was. Right here, hyper IgM syndrome. Absence of CD40 ligand that allows class switching from IgM to other Ig classes. So we just saw that, right? The CD40 ligand, I think it was 108, right? Did I get it right this time? What page is that shit, man? Oh, I'm going too far up. 103, okay. Right here, you can see the connection that you need to memorize and revise if you forgot is this thing right here. So you need the CD40 ligand to connect with the CD40 on B cells to actually have both signals necessary for class switching to occur. That way you can make IgG, IgM, Ig, whatever, right? All of the different immunoglobulins that will be necessary. So now you're missing that CD40 ligand. So now there's no class switching. So all this patient is going to have is IgM, the acute one that you make. But you don't have the other things, IgG and all of that. IgA, IgD is really not something functional. But IgE also, they're not going to have any of those. So very high IgM levels, low level of all other Ig, and normal numbers of lymphocytes. Severe recurrent sinopulmonary infections caused by impaired Ig. Treat with antibiotic prophylaxis and IVIG. Very straightforward. Very, very straightforward. Nothing crazy about it, right? However, what's crazy about it, unfortunately, is the resemblance is going to carry with some of these other things. Because now we're looking at something that the book says is a B cell issue, but it's a B and T cell mixed issue, because without the CD40 ligand, you can't have both of them working, right? They can't do that signaling that we just saw, the connection that you need between the ligand and the CD40 receptor. So now you have no class switching. It is X-linked recessive, which I think they did not mention here. So I don't know why they leave out little things in both books, right? That's, you see the benefit of looking at both books together. They mention something here, they don't mention it there. It's really stupid. So gotta make sure I can't write it right now because I don't save this with all the red marks I make, but definitely want to make a note of it. Right, this is X-linked recessive here. Put that in. Severe pyogenetic infections early in life, opportunistic infection with pneumocystis, cryptosporidium, and CMV. Right, so you've got the intracellular guys, the fungal yeasty guys, and viral infections. Right, all they make is IgM. That's it. But they cannot make these other guys. Failure to make germinal centers as well, which is what classifies the B cell aspect. Right, very similar to our guy up here. However, Bruton's, although there's no germinal centers, this is only a B cell deficiency. T cell is working, so they don't get those T cell relevant problems, right? Those T cell relevant issues don't occur here. Okay. So, I mean, I wish I had practice questions to look at. So when you do look at these practice questions from immunology, I highly urge saving screenshots of these things together. You know, make a file somewhere, and when you get questions for these topics, put them all together so you can look at the questions side by side to really see how they're different. The differences are in the infections, the age, the gender, as well as how severe it is and what helped, right? What helped. So that's your hyper IgM syndrome right there. Very straightforward, but again, a lot of overlap. Each of these is very straightforward on their own, but the overlap and the differentials is where the difficulty arises. Thankfully, though, treatment and checking for diagnosis, some of the key things that step 2 likes to ask are the same for all of them. Now, lastly, we're looking at combined disorders, and then we'll go to phagocytic stuff. So first thing they have here for combined is severe combined immunodeficiency, SCID, which was first discussed all the way in biochem, where the problem was due to adenosine deaminase deficiency. This is the autosomal recessive version, where without adenosine deaminase, this occurs. So look at what adenosine deaminase is supposed to do. Adenosine deaminase is supposed to take deoxyadenosine and make it into deoxyinosine, which then becomes uric acid, and you can pee it out. If you don't have adenosine deaminase, see, this is normal. Now let's see what happens to ADA deficiency. You don't have ADA, then all your deoxyadenosine will eventually become DATP. DATP inhibits the activity of ribonucleotide reductase, and without ribonucleotide reductase, all of these guys will never become these guys. And it makes sense why this inhibition occurs. You have too much DADP, so you stop yourself from making more DATP. But if you can't make more DATP, you cannot do DNA replication, which then messes up the formation of white blood cells. Right? Your immune system is one of the most notorious places where DNA replication keeps happening non-stop, because you make so many copies of the white blood cells whenever there's an infection. Right? So all in all, this is theoretically, in a sense, lymphotoxicity. So ADA deficiency leads to lymphotoxicity. Right? You end up having too much of the DATP, which inhibits ribonucleotide reductase activity. That's your adenosine deaminase deficiency mechanism of getting SCID, SCID, severe combined immunodeficiency. The other way is defective interleukin-2 receptor. Right? That's the most common, and it's also X-linked recessive, which once again will be in boys. And without the interleukin-2 receptor, you can now go back and see what happens. Let's see. Here again in this diagram. So if you don't have interleukin-2 now, then that's this one. You see interleukin-2 and 4, 2 times 4. Sorry, 2 times 2 is 4. That was one of our memorization things, to remember that interleukin-2 and interleukin-4 both give you Th2. Right, or 2 squared is 4, whichever, whatever you want to use. That was the number play that I was doing back then to help memorize these things. So interleukin-2 and interleukin-4 both give you Th2, but you don't really make much interleukin-4. Interleukin-2 is the main guy that helps you make Th2 cells, which then activate eosinophils to increase more IgE production, and you fight infection. Now you don't have that, right? Interleukin-2 on top of that, remember from your hot T-bone steak mnemonic, right here, interleukin-2 in general stimulates T cells. Right? Interleukin-4 is more specific for the Th2 variation that's making IgE in the diagram we were just looking at. Right? But interleukin-2 in general is the main guy that even stimulates T cells. That's also shown in the book earlier. Let me go right here. Right, so they tell you Th1, interleukin-2. Right? You need your interleukin-2. You need interleukin-2. So without interleukin-2, now you have a problem, right? And you can't do the correct things. So now you have a failure to thrive, chronic diarrhea, thrush, and you get a mixture of everything, right? Because it's severe combined. You don't have B or T cell function. So you have viral, bacterial, fungal, and protozoal, all of them, right? In your question, they won't mention all of them. In your question, they might pick the extremes. So there might be a bacterial infection like strep pneumo, as well as a protozoal infection. Now you're like, oh, that's a missing of a bunch of different things right there. Treatment: avoid live vaccines, give antimicrobial prophylaxis and IVIG, and you can do a bone marrow transplant. Once again, no concern for rejection because they don't have the T cells that are actually going to fight the rejection. right? So that's one of the mechanisms of helping them. Low T cell receptor excision circles, absence of thymic shadow, germinal centers are missing too, and there's no T cells, right? So that this is really a bad case scenario, right? You don't want anyone to have SCID, and there's two ways of getting it, so it's pretty common compared to some of the other ones. Here they tell you some of the same stuff, right? There's this thing here referred to as bubble boy disease, which is, it's from a movie. So this is a boy you keep in a bubble because it's like a boy with HIV essentially, right? Any infection will cause infection. Anything that can possibly cause an infection will actually lead to severe infection. So you treat them very much like as if they have HIV, right? You need to keep them in a sterile environment and everything. Severe frequent bacterial infections, chronic candidiasis, opportunistic infections requires PCP prophylaxis, but thankfully you could just do a bone marrow transplant and they'll be okay without any concern for rejection. However, as great as this might be, it's very hard to find bone marrow that you can actually give someone. It's very difficult sometimes. Even though there won't be a rejection per se, it's still hard to find bone marrow that you can use with different individuals. Rejection isn't the only concern. Next thing, ataxia telangiectasia. Love that it's actually named ataxia telangiectasia because the name tells you what you're going to see. You're going to see ataxia and you're going to see these telangiectasias, which are also called spider angiomas, right? And then the name has A in it, a bunch of A's in it throughout. It starts and ends with an A, right? Tons of A's in the whole name, actually. To remind you that there's also IgA deficiency. So similarly to IgA deficiency itself, you cannot give these people IgA blood products either, right? So this case scenario of not giving IgA blood products is not specific to just that IgA deficiency disorder. This is also an IgA deficiency disorder, but there's also other problems. So there's a defect in the ATM gene, which leads to a failure to detect any DNA damage. So once there is damage to DNA, it stays there. You don't repair it, right? And now that's going to be mutations, right? Any damage to DNA is a mutation. So now that's going to be mutations that are just prospering, right? And God forbid there's a very fatal mutation that occurs, there's no way of fixing it. Right? So these people, of course, have high risk of mutations in places that are generating a lot of copies of cells. So lymphoma and leukemia, you make a lot of replications of the DNA of your white blood cells, so every mutation is not going to get caught, so those mutations lead to blood cancers. Your blood, especially white blood cells, are the ones that make the most copies of DNA. They replicate their DNA all the time. So those mutations are not going to get fixed. All right. That leads to all kinds of problems. They're also very sensitive to radiation, which actually causes mutations on cells, right? But you repair them. We've all gotten an x-ray of some sort at some point, whether it was a dentist or some kind of hospital event, and we did have mutations from those radiation therapies or radiations that were done, but we recovered. These people cannot. Right? They also have elevated alpha fetoprotein, which is a very fucked up answer choice. Right? It's very difficult to actually think of that and pick it as an answer choice. If it comes to your mind, then great. Hopefully when you see it in an answer choice, it'll ring a bell. But it's I've gotten that wrong in the question actually, because I don't associate alpha fetoprotein with this. I associate that with notochord neural tube defects and stuff. So it's a dumb thing. And the ataxia is the most unique thing on this entire section. None of these other autoimmune conditions or immunodeficiency conditions have ataxia, but these people with ataxia telangiectasia, they actually have cerebellar atrophy, so they get ataxia. So ataxia mixed with weird symptoms and weird infections that are not common for people to get, plus possible lymphoma or leukemia, ataxia telangiectasia. You pick the answer. They're going to give you all kinds of things in that question. So they tell you right here: progressive cerebellar ataxia and oculocutaneous telangiectasias, autosomal recessive mutation responsible for repairing double-stranded DNA breaks. High incidence of malignancies, all kinds of mutations that are not being repaired, including lymphoma, leukemia, and gastric carcinoma. No specific treatment, may require IVIG depending on the severity of the IG deficiency. They don't really have a long lifespan either, because eventually they're gonna, their lifespan is not really solid though. We don't know how long they'll live. It really just depends on when they get that one mutation that led to a really bad cancer, right? So it can happen immediately, or it may never happen, and they'll live a fine life. You know, it all depends on their life and decisions as well. Like if they do things that further promote mutations, like smoking and sunbathing, you know, being in the sun with ultraviolet light, they're gonna increase the chances of them getting skin cancer. You know, their skin is gonna have mutations and it's not gonna recover. Now, there is a difference though, right? When you're in the sun and some of the skin cells get mutations, they could become cancerous, but they also just fall off, right? Skin falls off all day, every day, on our bed, everywhere we walk, when we shower. But the blood that they make with mutations inside of them never falls off. And if it mutates, it never breaks and dies. And if it never dies, it replicates more leukemic cells. That's why most of their malignancies are going to be very, very deep inside, and some of the most common ones. So keep in mind all the different cancers in this game of medicine and how they present, right? For example, gastric carcinoma is a very notorious one. Many signs of your body telling you you have gastric cancer, right? There was the Sister Mary nodule, there was the weird lymphadenopathy you can get on one side over here, and of course the various all these weird nodular things that occurred all over the back. That was another thing that occurred in one of them. So if we go back and look it up real quick, right here, gastric cancer, right here, see all of these things. So virchow node, left supraclavicular node, just one side. All right, Krukenberg tumor, which is bilateral metastases to the ovaries, and those ovarian cancers from here is a metastasis that's going to contain fat in the ovaries. That doesn't happen, right? But the gastric cancer, it does happen. Sister Mary Joseph nodule, which is just a periumbilical thing like that. It looks very harmless, but it's actually telling you that this patient has gastric cancer. And then the lesser Charlotte sign, that's what I was trying to say, right? The most common thing that's given in most questions for somebody with gastric cancer. So if you get a patient with your gastric cancer issue, then that's possible that that's how they're going to try to tell it to you. Instead of telling you they have gastric cancer, they'll tell you they also have all these things all over their body. It's a lesser Charlotte sign telling you they have gastric cancer. Right? So very again, very tricky ways of asking questions, right? They always try to combine things from different chapters. You have to be ready for that. Last one here is the WASP. I call this the WASP one, or the water game, right? Wiskott-Aldrich syndrome. This is how I memorized it. So let's see what it is first. So this is a mutation in the WAS gene. Leukocytes and platelets unable to recognize actin cytoskeleton, leading to defective antigen presentation. It is X-linked recessive. Right? So what's the water thing? So water, first of all, Wiskott-Aldrich is just a WA, so you don't need to memorize what WA stands for. It's just TER, and even the R you don't need to memorize because R is just recurrent infections, which is common in all of these things. So it's really just the T and the E that you need to remember, which is thrombocytopenia and eczema. Of all of these, the most important one to remember is the T, thrombocytopenia. Right? They're going to have thrombocytopenia, which is a character here. This characteristic is not shared with any of these other guys. None of these other immunodeficiencies have thrombocytopenia, right? Low platelet count. So you're going to see fewer and smaller platelets. Right? That's a key thing in Wiskott-Aldrich syndrome. So if you think of a WASP, then you should think of tiny platelets. Just think of it like that. You think of tiny wasps flying around, that's your tiny platelets flying around. So that's the only real thing here that makes it unique from the others. The other thing that they could do in a question is give you a number for each of the IGs. How many of it does it have? So if you look at the word or the phrase water game, the A and E are repeated twice in water game, right? You have AE, then you again have AE. So there's high, IgA and IgE. Whereas the other guys, IG and IM, are only repeated once, or only written once, not repeated at all, right? The G and the M. So those guys are low, or normal, but usually low. Okay, so that's what I'm trying to write here. And again, this is also just treatable with bone marrow transplant. That's it. They have a problem with actual platelets working correctly because they don't have good platelets. So now they have defective antigen presentation. It is also X-linked recessive, which means once again it's going to be boys presenting with this. All right. So let's see what they say over here. Wiskott-Aldrich syndrome. And so they have the white mnemonic here. viscoalgic infections, purpura, and eczema. Not really a fan. I think the water game does the job. Water game, where T is thrombocytopenia, and the game part just tells you what's high, what's low. And in water game, you write A and E twice, so A and E are high. G and M are normal to low. Patients rarely survive to adulthood. It's going to be mostly males because it's X-linked recessive. Only male patients. High risk for atopic disorders, lymphoma, leukemia, infections from all kinds of bugs. Think back to how IgM functions, right? You can't have response to these things without IgM. Treatment is supportive, and eventually the infections are going to add up and lead to more problems and basically just cause them to die. Okay. So this is all very problematic, very problematic. Last group of deficiencies are your phagocyte dysfunctions, right? LAD type 1, Chediak-Higashi syndrome, and CGD, chronic granulomatous disease. Chronic granulomatous disease was very high yield back in step 1. Huge topic regarding defective NADPH oxidase leading to decreased reactive oxidant species and decreased respiratory bursts in neutrophils. X-linked form most common. High susceptibility to catalase positive organisms. You have all of these as your catalase positive organisms. Okay, and candida may also be noticed. See diffuse granuloma formations everywhere. Abnormal dihydrorhodamine test in flow cytometry, where you're going to have low green fluorescence, and also the nitro blue tetrazolium dye test also is abnormal, so it does not turn blue. Right, so when you see these tests being used and they're not going the way they were supposed to go, so it's a negative test for both of them, that's CGD. Chediak-Higashi syndrome is a defect in LYST, lysosomal trafficking regulator gene. This causes completely different symptoms compared to some of the things we've looked at right now. Microtubule dysfunction and phagosome-lysosome fusion. So usually the answer is phagosome-lysosomal fusion disorder. That's usually the answer I've seen. It is autosomal recessive, and since their microtubule dysfunction is occurring, that's the thing that leads to most of the symptoms. So they get progressive neurodegeneration because they cannot have microtubule function to actually move things. And say in the brain, we saw this in Parkinson. In the brain, there are many neurotrophic things that are good for your brain, supply your brain, bring nutrition to your brain, stuff like that. Those things need to be transported to different parts of your brain. Now you don't have the microtubules to do the transportation, so you get neurodegeneration, lymphohistiocytosis, which you're going to see on the skin, albinism, which you'll also see, right, because they don't have melanin transportation, recurrent pyogenic infections, and peripheral neuropathy. Giant granules in granulocytes and platelets, like the one image they gave, right? All things are missing. Pancytopenia and mild coagulation defects as well. A very unique kind of thing compared to all the other things we just looked at today. Leukocyte adhesion type 1. This one is a defect in LFA1 integrin, CD18, which is actually a subunit of your beta-2 integrin. Right, so this results in an inability of leukocytes to actually migrate to the site of infection. So it's once again a chemotaxis issue, very similar to our other chemotaxis issue we just looked at, which is this one, Job syndrome. Right. So with Job syndrome, I always remember it as difficulty actually going to job, right? Going to where you work. So that's the travel that's not working. Can't go to work. Can't go to the job, right? So it's a chemotaxis problem, right? You can't go to the site. Impaired chemotaxis, impaired recruitment. So very similar to that, you have impaired chemotaxis here as well. Recurrent skin and mucosal bacterial infections. Now look at this. This is different from some of the other things we did. We haven't seen skin infections. Most of these things we were looking at right now were all infections inside. Respiratory, GIT, brain, not skin. Now we're seeing skin. So recurrent skin and mucosal bacterial infections. Absent pus, which is the main giveaway. They probably won't mention it. Impaired wound healing and delayed separation of umbilical cord, which is actually pathognomonic, but they probably won't mention that either. Right? If they're being nice to you and they have to mention one of these two things, then it kind of gives away the question and you'll get it right. Very high neutrophil count in the blood, that they can give to you. That's a tricky one. Right? All their neutrophils are stuck in the blood. It can't actually go seep through and go to where the infection is. And since it never reaches where the infection is, there's no pus. Even though there is infection, you won't find any pus. Alright. So that's the key thing right there. At the bottom here we have a simple question. 4-year-old Caucasian male is evaluated for recurrent skin and respiratory infections. He has light skin, silvery hair, eye exam presents horizontal nystagmus, peripheral blood smear shows giant cytoplasmic granules and neutrophils and monocytes. What does the patient have? Well, they just listed out every single one of these symptoms. They got the albinism, right? They got the horizontal nystagmus because of the neurodegeneration. They have the giant cytoplasmic granules, right? And then, of course, recurrent skin and respiratory, mainly the respiratory thing being the thing. They have pyogenic infections, right? So Candidiasis syndrome, phagosome, lysosome, fusion defect. Let's see now. I think that was all of them, right? We're done with that. We looked at CGD. So here they're listing out more of the details for those tests, dihydrorhodamine test that we talked about. Right, they say treat with daily trimethoprim supplemental, make judicious use of antibiotics during infections for CGD. Interferon gamma can lower the incidence of serious infection, which interferon gamma is the key thing for the G here. Okay, that's what I always think of when we see gamma, and when I see CGD, I think of interferon gamma, because you need to give this as well to lower the incidence of these bad infections that are occurring. Right. Bone marrow transplant and gene therapy are new therapies, and they can of course help pretty much any of these guys. You can see that bone marrow transplant, or just give IVIG if you don't need a whole marrow. Like in Job syndrome, you do make some of the other things just fine, so they don't need bone marrow. Candidiasis, same things we talked about, and then LAD, again same things we just talked about. So nothing new being added in. All right. So those are all your different immunology disorders. You want to be able to make a table for yourself where you list out all of these, and then from your mind fill in what each of them is about, what happens in them, right? What happens in them, what kind of infections you get, and how you fix it for each one of them. You should be able to, basically in a sense, kind of like a homework thing, you should be able to do it for yourself. You should be able to take a piece of paper, write down all the names of these diseases, and then talk about them without the book in front of you. Whatever it is you're missing, that you come back and refresh. And then of course, as you find questions for any one of these topics, put them all into one file so that you can compare those questions when you revise these immunodeficiency questions. In theory, these immunodeficiency questions are very easy, but if you haven't practiced them enough and you haven't seen the differentials, then you're going to be very confused between at least 2 answer choices, and then you're down to a 50-50 chance of getting it right. You don't want to play with that. So that being said, you want to go ahead and spend some ample time actually getting these guys down the best you can. Right? And then next time we'll continue on tonight with Kawasaki disease, which is another topic from step 1, but they love this in CK, very high yield topic in CK. It wasn't so high yield in step 1. In step 1, the main focus of Kawasaki, if you remember, was about giving aspirin to them, right? In CK, they don't really pick that answer choice of giving aspirin. They like to say give IVIG, which is also taught in step 1 as well, but they don't do that here. So we're going to see how that presents and all the funky ways you can get questions on it. But for now, I'm going to actually try to find today some questions regarding these immunodeficiency disorders. If I'm able to find a bunch of immunodeficiency disorder questions, I'll annotate them all into one place, and we'll try to look at it tonight or some other time. But we do need to do that. We need to look at practice questions to see how all these guys are differentiated from each other. Right? And then we'll continue from this and Kawasaki disease next time. So I'll see you guys later tonight.